I want to welcome everyone around the world to this global webinar and masterclass from the Vattikuti Foundation. I'm going to turn the program over to Dr. Gagan Gautam, who's head of uro-oncology and robotic surgery at the Max Institute of Cancer Care at Max Saket Hospital in New Delhi. And he's been a very good friend of the Vattikuti Foundation, has provided a lot of content for our website, and has participated with the Robotic Surgeons Council of India in many ways. And we really appreciate him taking time to share his expertise today and to be our moderator for this program. So with that, I'm going to sign off and turn it over to Dr. Gautam.
Welcome, good morning, good evening, good afternoon to all of you from wherever you are in the world. And today we are here to talk about something which is really up and coming, has really taken the world by storm when it comes to the treatment of bladder cancer. We've got two of the top robotic urological cancer surgeons from around the world to robotic cystectomies and intracorporeal diversions. As you would know, robotic cystectomy is fast becoming the standard of care as far as doing cystectomy for bladder cancers is concerned. But what we have seen is that we haven't really been able to decrease the complication rates to a large extent by the robotic approach when it's accompanied by an extracorporeal diversion. I think what we are really looking at now is that can we make robotic surgery or radical cystectomy less morbid and have a faster recovery of the patients and have less complications if we use intracorporeal techniques like ileal conduit and intracorporeal neobladder. And in Dr. Nikhil Vasdev and Dr. Karel Dedaecker, we have two renowned experts in this field. And I'm going to be introducing the first speaker, my good friend, Mr. Nikhil Vasdev, and then I'm going to be handing over the podium to him to speak on the robotic cystectomy, low pressure robotic cystectomy with ileal conduit urinary diversion. Professor Nikhil Vasdev is a consultant urological robotic surgeon and associate medical director for cancer services at the East and North Hertfordshire NHS Trust, Lister Hospital in UK. He is a senior clinical lecturer at the School of Life and Medical Sciences at the University of Hertfordshire, where his research group focuses on cytokines and robotic surgery. His research interests include biomarker research and health economics. He has published over 170 peer-reviewed papers and was recently awarded the International Professorship by the Apollo Hospitals Educational and Research Foundation, India. More than that, I think we all know Nikhil to be an excellent speaker and an excellent surgeon, and we really look forward to having him and telling us about robotic cystectomy. Over to you, Nikhil.
Thank you very much for that very kind introduction. And thank you to the Vattikuti Foundation, Dr. Bhandari, Dave and Joanna for the invitation. I'm just going to start off, if I may, with sharing my screen. My talk at this very important masterclass is on a concept of low pressure radical cystoprostectomy. And I'm going to be talking to you about why low pressure robotic cystectomy seems to be the way forward. I'll be sharing some data that we've been working on a clinical trial for which I'm the chief investigator in my center, looking at gut cytokine levels in low pressure and how complication rates are dropping, patients are going home quicker, and also some basic science work in my lab that we're leading on, which I'm collaborating with Karel very closely on particulate matter research intraoperatively in the context of low pressure surgery. So the talk will encompass some latest evidence on robotic cystectomy. I'm going to talk about port positioning and the XI-SI intuitive system and some new work that I've been doing with the CMR Versius robot for port positioning and some important considerations with aerosol research. So there is a big difference between open cystectomy and robotic cystectomy. The top picture is an open neobladder. You can see the patient ends up having a large incision. Obviously, the procedure is performed via the open route, but a majority of the clinical trials which are making their way through, which are being published, largely involve the robotic bit being removal of the bladder with a lymph node dissection, but the reconstruction i.e. the urinary diversion being open. So the question largely comes up as to whether by making an incision during a robotic approach, which is minimally invasive, we are negating the benefits of minimally invasive surgery. The next part is essentially a transition from robotic to open cystectomy or open to robotic cystectomy, whatever suits you with regards to your expertise or what you want to pursue. But my talk largely encompasses some research that we're doing with ConMed with the AirSeal device, in which we are being able to drop the intraperitoneal pressure right down, and the benefits we are seeing in the context of patients' recovery, the reduction in complications, the reduction in pain. And my research fellows have worked pretty hard over the past 2 weeks to get data ready for this meeting today. So let's just spend a minute looking at what happens when a patient's abdomen is insufflated to create a pneumoperitoneum. So we have different insufflator systems which are used. And I have published fairly extensively on this, looking at what impact this tends to have, the pneumoperitoneum tends to have on renal function and physiology when patients undergo robotic renal surgery. And this led on to the conceptualization of the development of the low pressure program, which I'll touch upon in due course. So the pneumoperitoneum, when it's created, no matter whatever source you use, the impact on any organ intra-abdominally is both direct and indirect. So in the kidney, the direct impact happens because of vascular resistance due to compression of the renal vasculature, direct compression of the renal parenchyma. And you can apply the same sort of hypothesis and theory of what is happening to the gut too. And you can also have reduced renal flow secondary to vascular resistance, renal perfusion pressure due to pneumoperitoneum. But the indirect impacts are largely down to compression, but also down to different mechanics and metabolism issues within the kidney, such as the renin, angiotensin, aldosterone system being affected, and some neuroendocrine responses. If we go to look at cystectomy, robotic cystectomy has been a concept which has been floated since 2000. And I must admit that when I became a consultant urologist in 2014, after finishing my fellowships up in the UK and the US, and I came back, it did take me a little bit of time to go from a position of being able to do a fairly decent open cystectomy to a robotic cystectomy, and then to a complete robotic intracorporeal program. So my past 70 cases that I've done have all been completely intracorporeal. I do not do any open reconstruction if I'm doing a robotic cystectomy. So the fact of the matter lies that, which Gagan has mentioned more importantly, is that patients' complications such as the readmission, even if they have to come back in relationship to a bit of a UTI or not feeling quite right, is high with robotic cystectomy. And I'm going to show you some data on a publication that I published last month in BJUI Compass on the largest UK series of cystectomy. So let's just talk about robotic cystectomy. So my standardized approach for male-female cystectomy is fairly similar. The only thing which I've changed after the first 20 cases was I used to do a extended lymph node dissection first, and then I went down the route of converting to doing the cystectomy. But now what I tend to do is I do the cystectomy first, then I do the lymph node dissection, and then I do the intracorporeal. There is nothing wrong between step 1 and 2, whatever you prefer, but this is something which comes over time, because I used to note that I was spending quite a lot of time doing a lymph node dissection in the beginning, and there were some issues such as bleeding, a bit of ooze. So I decided to go down the route of just doing the cystectomy first, after speaking to my friend, mentor, Karel, who's on, and I'm delighted to be sharing the podium with him today, who really, we collaborate a lot, and we tend to work in a uniform manner together. So the real difference that I've noticed, so this is a nerve-sparing cystectomy in a male patient who's 42, that I did, who had a neobladder then on. But on the right side is on Thursday, I did a lady who had high volume lymph node disease. She had an intracorporeal ileal conduit. This lady was 50. And during COVID, we certainly are seeing a little bit more change with the advancement of the disease coming through. But the real change that has taken place in practice right now is with the robotic vesisealer. So this is a device that I use in all my cases unless I'm doing a nerve-sparing case, of course. And on the XI system, the implementation of the new robotic vesisealer and even newer energy devices, such as the SyncoSeal device, ensures that your dissection time is pretty quick. So I will not use any clips whatsoever on the inferior vesical pedicle or superior vesical pedicles. I will use the robotic vesisealer, which is fairly quick. And my entire team is now trained up to do robotic cystectomy. So it's not only about you, it's about the anesthetist and the team. I do a sort of cystectomy within an hour, the lymph nodes in about 45 minutes, and then intracorporeal conduit in an hour. So the operating times for a robotic sort of cystectomy with the training case is about 3 hours. With a neobladder right now, because I still feel I'm very much on my learning curve with neobladders, is about 5 hours, could be 6 hours sometimes with the recon involved. But as anything else in life, as you do more, you get better. And that's the same concept being floated. So this is the setup on the SI system. So a majority of the cases that we did on the SI system. So this is the head end of the patient, that's the bottom end. So we put two 8mm robotic ports. I use a 12mm port with a port-in-port technique for the fourth arm, which is very useful because for stapling, you can move the port in and out. The only change which has taken place now is that I use a 5mm port on the top because all the stapling happens from the side port. I used to staple from the top with a few neobladders, but that has been implemented into one port itself. On the XI system, this has been a game changer. So we had the XI system delivered as a June console not too long ago in my center. And I've done 11 cystectomies with this, but I've used the robotic stapler, which is a very important, good tool to use. And I'll show you a video of the intracorporeal conduits that we're doing with the robotic stapler. But clearly, this has a role to play, and I'm sure the technology will improve. But the docking of the XI is fairly similar with the port positioning that I showed you before. So we are working with CMR. This is a new robot in India. There seems to be a lot of CMR systems being installed. My data indicates that we have 17 systems with more on order. And what we've been able to do is now develop a standardized technique for a 4-arm CMR versus cystectomy with an intracorporeal reconstruction. So we've been able to do this successfully. This system is slightly different in which you have different arms, unlike your cart from Intuitive, which has lots of arms coming through. So we're in the process of publishing this as a first case of intracorporeal reconstruction, but port positioning, again, is fairly similar with the Versia system too. So exciting to see a new robot being used for a cystectomy and an intracorporeal reconstruction. Now, COVID is amongst us all. It is frightening to see this virus, the way it behaves. There are peaks and troughs with how COVID happened, but let's just focus a little bit now on the angle of low pressure that I'm keen to present and discuss with you. So the controversy around COVID, when the data started making its way through in February, March last time, in 2020, when the pandemic was sort of showing face worldwide, there were different organizations which said that minimally invasive surgery is not a safe option to pursue due to the risk of aerosol and transmission. So we've done a lot of work on this, and I'm going to show you some data from my center. But essentially, the COVID particle is slightly smaller than the standardized viral particles that we see in practice. HIV is around the same size, but HPV and hepatitis C is slightly bigger. So what we did was we used the air seal system with the built-in filter. So those of you who don't know what the air seal system is, this is just an introduction to the system. So it's an insufflation device that allows you to maintain a stable pneumoperitoneum and constant smoke evacuation. It has the benefits of access ports, and it has triluminal tubing, which provides CO2 insufflation, a stable pneumoperitoneum, and smoke evacuation using a ULPA filter at 0.01 micron. So the way it works is it's got different barriers within it. You have CO2, which goes in and out. You have a continuous smoke evacuation. But on the whole, once the air seal mode is activated on your insufflator box, it kind of maintains an equilibrium to prevent overpressurized scenarios. And that's important to consider both with direct and indirect effects of CO2 in the abdomen in the context of pneumoperitoneum insufflation. So what we did was when the pandemic started off, we had a choice of either stopping all minimally invasive surgery, which a lot of centers stopped in my network, but we decided, and we looked at the evidence with my executive board and being the associate medical director and lead responder for the COVID cancer response of my trust, we decided to change the way we operated a little bit more. And this has consequences not only in the context of operating in the COVID scenario, but we also learned a lot of new things by making incisions smaller to prevent any gas leak and surgical emphysema, for example, which is an issue which has been mentioned in the robotic cystectomy context, because when you start operating, you might take a little bit longer with your learning curve. And all of us have seen this when we start doing robotic cystectomies. It's a different operation altogether, especially when you add on an intracorporeal reconstruction at the end. So what I use is I use a BTT port to start the initial insufflation, but the concepts are low flow, low pressure, and low smoke evacuation. So these are the three things that I've been doing now with the robotic cystectomy cohort of patients. And again, when you're putting your ports in and out, take a lot of caution to ensure that there is no sudden gas leak to prevent. So these were cases we were doing because we didn't stop our robotic cystectomy program during COVID. These patients were tested. None of the staff was vaccinated. There was a lot of stress about whether it was safe to do minimally invasive surgery, but we pushed the border, and luckily we were lucky to carry on, and our patients benefited because with low pressure surgery, they had less pain. They did not need to go to the intensive care unit, and they were going home quicker. So we managed to address all issues. Another thing which I do is I close all my robotic ports intraoperatively, and I've discussed this with Karel, who's been to my center lots of times to help me out and mentor me. And we use the buffalo filter during surgery to allow continuous evacuation. Now, we did 345 robotic urological procedures from March 20 to March 2021. And you can see that we stopped doing prostates for a couple of months. But what we found was that we had 0% COVID at 30 days. And also, there was no association between the theater staff infection rate to them being in theater. We've published in this in European Urology, multi-center cohort study, not only looking at air seal, but on the whole, how safe it was to perform robotic surgery or robotic cystectomy, especially during the pandemic. And we again found that the number of people who developed are 599 patients, 0.7% risk of COVID, and there was no mortality. And you can also introduce a training program to run during the COVID pandemic. So on the whole, very positive data with robotic surgery. Now, I want to spend the next few minutes telling you about what we've been doing on particulate matter research. And this fits in quite nicely with some of the steps that I showed you in my last video during robotic cystectomy. And I've been working with ConMed in the United States in my research lab at the University of Hertfordshire, where we've been looking at different scenarios. These slides are slightly busy, but I'll just try to summate them as quickly as possible. So what we did was we developed an experiment in the laboratory in which we developed a bladder cavity to mimic the human abdominal anatomy per se. And we did a lot of testing of leak of gas intraoperatively taking place. So the scenario was a piece of pork, a diathermy machine, and we set up different insufflator catchment systems to see if we could look at particulate capture. We also looked at the development of the addition of a balloon port with a continuous buffalo filter, which I showed you in my video, to see whether the addition of a buffalo filter has a strong role to play in the context of reducing the particulate matter spinning around in the abdomen cavity during surgery. So these were different situations that we looked at. So again, particulate matter filters. We also looked to see if instruments going in and out, and I'm going to show you a video of what we did with something called a linear accurator, which mimicked the human hand moving in and out of the air seal port in the lab to see if this led to a sudden release of particles outside. There was a risk of particle release. And what we found in our data, which is pretty amazing, again, reinforcing that low pressure surgery with a low flow is safe. So this reinforces the message that you can add on a suction device, you can make the situation safer. And we found that about 95% of the particles circulating in the bladder cavity, in the abdominal cavity, clear out in about 5 minutes with using a low flow system, which is reassuring because I personally would have thought it would be longer, but it's about between 3.5 minutes to 5 minutes. We also found that the number of particles being collected do not dissipate suddenly in the air seal situation when you remove an instrument because of the filter systems being built into the device. And this is some really good data which we are working on right now. Now, just touching upon the current state of play with robotic cystectomy. So like I said, a lot of surgeons will do the cystectomy, they will do a lymph node dissection, and then they will do the diversion open. But hopefully we are here to convince you that robotic intracorporeal ileal conduit diversion is the way forward. So this is the paper that I published last year. in which a summation of the trial showed that most, if not all, of the studies published are extracorporeal. We also just published this in BJUI Compass, which is on 12,625 cystectomies in the UK. We have about a 40% neoadjuvant uptake rate in patients undergoing open robotic and lap cystectomy, but robotic cystectomy is on the rise. So right now, it was about 10% in 2013. It's about 39% right now. And 2021 data indicates a 51%. So we are seeing more robotic cystectomies on the rise and a significant reduction in open cystectomies take place. So that's statistically significant. When it comes to complications, the length of stay is lower with robotic cystectomies, about 8 days. The length of readmission is lower, but the complication rates with regards to ileus and UTI on my Cochrane review still seem to be similar. And this is largely down to a Cochrane review, which looked at robotic cystectomy with an extracorporeal diversion. And the focus purely right now is not on intracorporeal diversion, but I'm a principal investigator on the IROC clinical trial in the UK, and hopefully we'll have some exciting data come through shortly on the difference between intracorporeal diversion versus extracorporeal diversion, but the commonest complications continue to be UTI and ileus. This steps us on to some of the research work that we've been doing. So Karel is right there in the picture, and we collaborated on something called cytokine-guided robotic cystectomy, in which our main benefit we saw with patients having robotic intracorporeal diversion was, how is the ileus rate lower? Why are these people going home quicker? So we sat down and we had our initial meeting, and Gary Tegan from the US came across, and Nimish Shah from Cambridge. This is my niece, it is Gary Mohan. And we have just published on prostate. So we've looked at data in patients being randomized between a pressure of 12 versus 15. And we have found that ileus is lower at a lower pressure compared to a higher pressure. So this is in press right now in current urology. And this is fresh data. I'm very, very grateful to John Pedad and Arvind Nayak, my robotic and my research fellow, who've got this data ready, in which we have a trial which is looking at cytokines with intracorporeal diversion, for which I'm the chief investigator, in which we are randomizing people between 12 and 15. And this is data from 14 patients right now. I don't have cytokine data yet, but this is purely clinical data. And what you can see is the ileus rate is lower. So it's about 14%. So 1 out of 7 patients versus 42.9%, 15 patients. So there is a strong role to play with intracorporeal diversion. And again, people are going home quicker. These are patients who are having neobladders and ileal conduits robotically. So there's no open diversion taking place, but this reinforces how quickly the patients are going home and the ileus rates are lower. So this has a strong role to play in due course, of course, in clinical practice, again, proven by cytokine work that we're doing. Now, the last part of my talk was on a robotic ileal conduit. So my practice is about 80% robotic ileal conduit, and 20% is neobladders. This is just a video which I haven't really edited much. Essentially, what tends to happen is, this is the ileocecal junction. I probably go about 22 centimeters from the ileocecal junction, which we've been taught. And again, I do manipulate my cardia in arm 1 and arm 2. I put a stay stitch in, which is 20 centimeter stay stitch. On the end of the conduit, that'll be coming out to form the stoma. So a couple of knots in that. So we've started using the robotic staple gun. The difference that I've noticed in 7 cases that I've used the staple gun on is I was using the iDrive Covidian staple gun. This is a very intricate staple gun because the entire onus on the stapling now lies on the surgeon, as against the dependency on your assistant. But again, it could go either way. If you have a very, very fluid team, it's good. Once I apply the staple gun, I tend to lift off the bowel just to make sure that there is no risk of an injury to the area where you've done your extended lymph node dissection on, especially near the right common iliac vein or artery, which is just below this area. The stapling happens from the console. The robotic stapling happens from the surgeon console. It takes a little bit of getting used to, but I think in about 2-3 cases, the learning curve is fairly small with this. The only difference that I have noticed so far is a little bit more ooze from the staple line compared to a Covidian staple gun. And when I've looked at the manufacturer's guidance, the staple on this particular robotic staple is 3.5 millimeters, whereas your Covidian is about 2.5 millimeters. So probably the staples are slightly smaller, but the bleeding is not substantial in any way or form. It's a minute amount of bleeding which can easily be controlled with a short burst of monopolar diathermy onto the staple line itself. So that's just just a few short bursts of monopolar diathermy, and you'll be able to get it under control quite nicely. So once this has been done, you've identified the stapler. You sort of fire the gun on the other end of the conduit, and again, using the staple device, you can do a side-to-side anastomosis of your ileal conduit. All I tell my fellows when they do this, or when I'm doing this, is to be a little bit careful, because the robotic staple gun does have slightly broader movements than what we're used to with a robotic handle, Cartier, or a bipolar forceps. So this is important to take on board. But it's a calibrated stapler which applies sense level pressure. And this is the last staple line, which I feel is slightly better to do as a surgeon, because you're really able to angulate this properly when you fire the staple through on the top end of the anastomosis. Upon the completion of this step, I will then put a few reinforced sutures with Vicryl Trio, just to prevent any buckling of the anastomotic site. I will then use my bipolar to peel the mesentery off the end of where I want to make the anastomosis. So I always do a Wallace unless I really need to do a Bricker, and I'll show you some data on my stricture rates, and this is done using a cold scissor. My assistant will then come in with laparoscopic scissor. Now, I have also evolved a little bit with the suturing between the base plate. So I use a bipolar in my left hand, and I use a 5.0 PDS. I used to use a 4.0 V-lock. And I think when I did a case in Delhi and Gagan and I spoke, we mentioned probably using a different suture. And Karel also highlights that I should use a PDS, which I enjoy. The only thing is the suture is very fine. And because of lack of haptic feedback with a robot, you can snap the suture. So I use a bipolar in my left hand. With a needle driver, sometimes the memory stays and the stitch can break. So it's slightly frustrating because you really need to start off again because it's a continuous suture that you're using. Another change which I have done is once the anastomosis is over, is I use Banda stents. I used to use JJ stents, which was slightly quicker, but I had a few issues with stent blockages with mucus. And there were two people who had a leak, and I had to take them back to theater and change the stent. So I use a Banda stents over a sensor guide wire, which is a hydrophilic guide wire, and put these through both the ureters. Obviously, again, lack of haptic feedback, you can end up buckling the stent too much. Once the stents have gone through, I will place a Cartier through the conduit to grab the stents all the way down. So be a little bit careful when you're doing this step. You don't want to avulse the mesenteric border down here, which I've seen once happen with a big hematoma, which luckily got controlled with some Eversil, and you can pull the stents across. So this is sort of ileal conduit in a nutshell of how I do it robotically. Now, some data on this. I have done 107 robotic ileal conduits versus 101 open, and I've compared this data. My stricture rate is probably slightly higher with the robotic ileal conduit. And the stricture rate is 6.5% robotically, and open it's 3. Left-sided strictures are more than the right. In 3 patients, I've had to do a nephrectomy because the kidneys were probably obstructed for a while. But I've had 4 successful, 1 robotic reimplantation on the left and 3 open reimplantations on the left. On the right, I think it might be quite hard to do a robotic reimplant, challenge-wise with the anatomy of how you want to locate the base of the conduit, etc. But left-sided is possible. Again, it depends on where your stricture is located. So I'll wrap my talk up in time. So thank you very much.
Thank you very much, Nikhil. As usual, you delivered a fantastic talk in a very crisp and very, very effective way. Really amazing to see the excellent work that you're doing, not only surgically, but also in the research field, which we feel really adds so much more to what you do and what we learn from you. I'm going to ask you one quick question, Nikhil, and then I'm going to move on to Karel. And
sure.
And we're going to have a little bit of a roundup at the end with everybody pitching in with the questions. The question that I have for you is that you doing a low pressure cystectomy at say a 5 or an 8, because one of the pictures you showed actual pressure was 5. Do you encounter any technical difficulties during that? Do you have any issues with hemostasis? And if yes, how do you overcome it?
So Gagan, that's a really important point. Yes, the technical difficulties are that I can't insufflate the abdomen to a great extent. So I might go up to 8 when I'm doing the cystectomy bit. This patient that I had showed the video on had a lung transplant in the past. So the anesthetists were pretty keen for me to maintain a low pressure to reduce the afterload because he had a degree of pulmonary dysfunction. So I might start, I might do the lymph nodes at 5 with a conduit at 5, but sometimes if there's a bit more bleeding, I might go up to 8. So it depends, but I tend to maintain a steady pneumoperitoneum. The issue is that on the cytokine data that we did, when you fluctuate the pneumoperitoneum, there's a cytokine surge which happens. I don't know why. So we're still looking into this on animal-based modeling right now. The reason why I'm in the position of confidence to drop the pressure down to 5 is because of the kit that we have with the robot. So the vesisealer, which I'm sure I've discussed this with you in Delhi, and I know you use it, I think is a very good tool to prevent bleeding. But there will be probably slightly more ooze, but one must appreciate that if someone bleeds 50 ml in the context of a cystectomy, it's not a big deal. We are so used to no bleeding at all as robotic surgeons. Even 50 ml seems to be a lot. But traditionally, an open cystectomy, like 500 ml was not a big deal either. So I think more technology will make its way through, but adjuncts such as the vesisealer, the Syncoseal, which is the RFA blade device, which I used the other day with Intuitive, has a role to play. And the newer robotic systems, such as Versius, also has got new energy sources coming through. So I think they'll help us maintain a lower pressure. Thank you.
Yeah, great, Nikhil. I believe, sometimes when the pressure really drops, you have a lot of problem with the bowel coming in the way. It's invariably, it's the bowel which tends to block your access to the bladder, to the pedicles, and even to the lymph nodes, the proximal portion at least. Do you feel that you have to compensate that by going in even a steeper head down than you would usually do if you're doing a low pressure cystectomy, or in your experience, it really doesn't work that way?
I think, Gagan, I may undock in the middle to do the, and flatten the patient a bit more, i.e. do the cystectomy in a slightly more steeper head down position, about 35 degrees, and then undock to go to, say, 20 degrees to do the recon. But now with the integrated table, we control that on the console, so we don't have a problem. But you're right. If you have a high BMI patient, you probably would struggle to do a cystectomy at 5. So it's one of those things. But I think individualized based pneumoperitoneum pressure, change the position in the middle if you need to, and that's the way forward. But the key is to ensure that you don't get stressed because it's a long operation. What you don't want is continuous fighting taking place. And the advantage with the air seal is that even if you have a sucker in full blast, the pressure doesn't drop. So I think that's what keeps the view intact. Because if you have a system in which the pressure drops suddenly, you lose your view and the bowel comes forward. So it's just one of those small things.
Absolutely. I think 2 important points that you're highlighting is the fact that you have the flexibility to change the position at any time with the integrated table, and that you have the air seal. And these 2 are probably the 2 technologies that is helping you, get all these excellent results even at low pressure. So you hold on, Nikhil, don't go away anywhere. We'll be back catching you in the next 20 minutes or so. And now the man on the hot seat, so to speak, is Dr. Karel Dedaecker. He's a very well-known robotic uro-oncologist from Belgium. He's the head of clinics at the Department of Urology at Ghent University in Hospital in Belgium, a fellow of the European Board of Urology. And he's also, like Nikhil, a very well known academic. He's done a PhD and successfully defended his thesis on metastasis-directed therapy of oligometastatic prostate cancer relapse. And right now, he's the senior professor of uro-oncology at Ghent University since the last 3 years. So over to you, Dr. Karel, and you will be speaking on intracorporeal neobladder. We're all looking forward to hearing from you.
So thank you very much for the introduction. Congratulations also, Nick, for your nice presentation. And thank you for the invitation that I can share my experience with you. I prepared some things about Neobladder to be able to close this off in a rather short time frame, but I will keep on to the most important things. The first thing that I want to say is that with robotic surgery, we are able to have more sex organ sparing radical cystectomy. And this is important also for neobladder function. We know from open surgery and from the Studer series that certainly in female patients, if you can save vagina and uterus, you have a better function of the neobladder. So intracorporeal diversion, Nick has showed the ileal conduit, and I will show you the intracorporeal, the orthotopic neobladder. You can also do a heterotopic one, but I will not cover this today as this is very rare to do. Just to show you what the results that we were having, I started with intracorporeal diversion very early on. So I did maybe 5 extracorporeal and then I switched to intracorporeal. Now have done around a bit more than 300. And we have seen a drop in our high-grade complication rates. It halved, and also the length of stay, but this is what comes out even in the extracorporeal diversion, it goes down. But I believe that with intracorporeal, you can have a reduce the complication rate. About the neobladder results, what I have seen in my series is that we have a good continence rate. After 3 months, it's about 2/3, and after 6 months, it's daytime 95% and nighttime around 80%. So continence means here 0 pads or 1 pad for a few drops. Regarding the need for catheterization, this is of course important. It is common in female patients, probably because they have some kind of descensus after a while, because they strain. In male patients, it's very rare. It's only 5%. About potency, if you can do, if it is oncologically safe, of course, if you can do bilateral nerve sparing and the erections were good beforehand, then around 2/3 of the patients will be able to have erections, and the same for female patients that you did sex organ sparing cystectomy, also around 2/3 can have sexual intercourse with penetration. So I have some tips and tricks to share with you. This is my setup. I'm working with an XI, as Nick is now doing, and this is the setup. So I have a right-handed assistant, and at the most lateral left port, I use the robotic stapler because I like it very much. Before I used the laparoscopic one. So these are my right hand scissors and needle drivers. In my left hand, I'm having a bipolar and I'm exchanging the bipolar. So in my non-dominant hand, I'm using now the synchro seal or the vessel sealer extent. And then at the most lateral left hand, I'm using a Cadier forceps. It's important, please don't use progress forceps. It's not good for bowel. And then this is exchanged for the Schulform 60 regarding the stapling moment. We use the ping pad to position the patients. You can have 40 degrees, but I never use it actually. Normally, my patients are at 25 degrees of Trendelenburg position. And as we have discussed just a few minutes ago, in obese patients, you might need 30. Of course, as Nick has shown, I also switched 2 years ago to low pressure, and I'm always working around 8 millimeters of mercury, and this is feasible to do all steps of the surgery. You have enough space, and it's very stable working environment. And it is not only low pressure, it's also as less Trendelenburg as you need, and as I said, it's 25 that I'm using, and with the integrated table motion, it is very it's very fast to change from, for example, 25 degrees for the cystectomy moment to, I'm normally going to around 10 degrees for the neobladder surgery. So this is actually the beginning of the neobladder surgery, and in 1 minute you're there. And if it is not good enough, you can have even a little bit less, go to 5 degrees. If it is too much, you can go back. And this is only with having your fourth arm, third instrument out within a minute. So this has helped us actually. And we have looked at the change in postoperative care after we introduced the low pressure and the integrated table motion with as less Trendelenburg as needed. So, and what we saw is that certainly the anesthetist was very happy. They had less problems for ventilation, less acid-basis disturbances, less electrolyte disturbances. And actually, because we started using this, not a single patient has to go to intensive care anymore. So all patients can go to the normal wards after surgery. I wanted to share some things that I saw also in the presentation of Nick, which is important about dissection of the ureters. If you want to reduce the stricture rate, I think the robot is a very good tool actually to try to reduce it. And you have to go back to the anatomy, and it's most often, as we have seen, it is the left ureter that is always the problem, because we have a longer dissection of the left ureter and we have to cross it from the left to the right. And what you have to save, what you see here, these are all the vascular supplies. You will have to sacrifice the one from the internal and the more distal ones, but you have to try to save, to spare the one from the common iliac artery or from the aortic bifurcation. And this will be helpful. And I will be showing you in this short video here how we mobilize the left ureter in order to try to have less stricture. So the steps that you have to do is that certainly we try to avoid direct grasping of the ureter, so always have a little bit of fat or facial tissue, have indirect retraction. In the beginning, I used vessel loops actually to avoid grabbing the ureter. Now I don't do it anymore. I do like this. You go around it. These are the vascular supplies that you control with bipolar. So the current is not going into the ureter or the vasculature that is around it. We use this suture at the end of the clip to be able, and this is the important step here. So if you have to mobilize further, you have to stay away at the medial side to be able to save the pedicle from the common iliac artery. And now this will be the crossing from left to right. It is important that you have a broad window, so the ureter is not kinking. And you will see here, so we were able to spare their, that pedicle from the internal iliac artery. If you want, you can even, this is a patient from 2 weeks ago, you can even check this out with ICG, and you see exactly there that you have, where the pointer is going, that you have saved that vascular supply that is going to the ureter, and then you can follow the ureter and see that the left ureter is indeed vascularized until the end. And I was surprised actually that the right ureter, you see here, the last 5 centimeters of the right ureter were to be sacrificed because there was no blood supply in it. And in the beginning, this can certainly help you as a surgeon to have a look where you have to go. You can also look at the bowel, but we will skip the bowel now. And then if you start incising, spatulating the ureters, you have to go into the green zone before you start to do the bolus plate. And if actually the left ureter is not well vascularized, because it's most often the left ureter, then you have to keep on spatulating until it is. And then you better, because it is short, you better switch to a separate anastomosis and not use the bolus plate anymore. Normally I'm using a bolus plate, but not in case of bad vascular supply. So regarding the neobladder, I'm using the Karolinska modified Studer technique that is shown here. This is the basic principles. I have changed it a little bit with using a little bit shorter left loop and a longer right one. So if you double fold, I'm double folding actually now from the left side to the right side, then you still completed the double fold. There are many Neobladders. This is the University of South Carolina, so it's actually more or less the same. They have 40 centimeter of Neobladder bowel and then the chimney on top. But then before the anastomose, Karolinska is starting with the anastomosis, but here they start with doing the posterior wall, and then they turn it around 90 degrees and do the anastomosis at another spot, so they can at the end double fold again the neobladder very well. So it's very nice, and theoretically it's good, but I was not very successful in trying this because after you did the posterior wall, when you have to turn it around, it's very difficult because you have the tension on the mesentery. So this is another one from a group from Switzerland, and they come closer to the real Studer. So they start with 10 centimeter and then add another 10 and then 20 and 10 for the chimney. And then they double fold differently. So you have not a vertical posterior wall, but actually a horizontal one. And then they double fold again here. And then you have this kind of, it's good neobladder. I tried it a few times, but you have a very big left belly that can actually flip or turn or twist the anastomosis with the urethra. So then I had to fix the neobladder to the pelvic wall or to the pubic bone even, to be sure that it is not twisting. Because if it would be twisting, you could have retention, but it's not a bad neobladder. Pyramid neobladder is another one, very simple, 25-25, and you save the last 5 centimeters to have the ureters anastomosed to. They do posterior wall and then start the anterior wall, and that's a little bit something that I don't like, because then you risk to have funneling here. If the patient is standing upright, you could have a funnel and this could be kinking. The other thing that I don't like is that actually you have a 4-country point where everything comes together. This is the least vascular point that has a risk for leakage. And actually at that point, certainly don't put a catheter in. Houtman neobladder, also possible robotically. Actually, whatever neobladder that you do, it can all be good, some advantages or disadvantages over some others. The most important thing is to double fold. I will try to show you my technique that we are using. So the first thing after having reduced the Trendelenburg is that you need to have the sigmoid out of the pelvis. So I always clip it to the left iliac fossa, and then you have to start moving around with the bowel, bringing the terminal ilium into the pelvis, identify the cecum, save 20 centimeter, as Nick has shown also for the yellow conduits, it's the same. And then the assistant is holding that stay suture. And if you run down the bowel smoothly towards the urethra, you have 20 centimeters. And that's actually the place where I do the anastomosis. So this is the very first thing that you do, is making the anastomosis with the urethra. This is a kind of Rocco stitching that we do first. So first start with the posterior wall, having seromuscular tissue fixed to the recto-uretralis muscle or the non-veliz fascia, and then starting actually with the true bladder anastomosis. It's a little bit bloody here, but that's because you reduce the Trendelenburg. I'm using a Bart suture. This is a 3-0. It's not V-lock, it is quill or Stratafix, and because it is barbed, you can gradually increase your tension. So then the next thing, this was still actually with the laparoscopic stapler. Now I'm using the Sure form. And regarding that, it is important to realize that instead of using the blue reloads, Nick, as you have shown, I have started now using the white reloads, and indeed, you do not have that oozing anymore from the stapler line. And the white reloads that are normally the vascular reloads, you can really use them for small bowel. The last 25 cases I did were all with the wide reloads, and it's working perfectly. So this is after having left and right stapling. You need to make sure, that's the most important, that you have a very broad, wide base for your vascular supply of the neobladder. So this is the same actually as an ileal conduit, side-to-side anastomosis. So if you stayed close to the stapler line, you can finish it off with 4 reloads. You don't need more. I'm not doing a second side to side. I'm only doing 160. Then we have to open and detubularize the small bowel. The moment that you come closer to the urethra, of course, you go to the mesenterial side. Otherwise, you open your anastomosis again. So I'm having here, in this case, 20 centimeter at the right side, and then again 20 centimeter at the left side. Then we start with stay sutures every 5 centimeter. So the fourth arm is every time holding the stay suture, and here we are going down with the stay sutures, and then we will go up with the posterior wall, and then we use the V-lock here. So you see the assistant is holding one side, I'm holding the other side with my fourth arm, and then you can run the V-lock in between. Then the double folding. So this is still the technique where we had 20-20, and then you double fold from right to left. Actually, now I'm doing more 17.5 and 22.5 and double folding from left to right. It is all the same. The thing is that you cannot completely double fold on the stapler line because then there is too much tension, certainly in male patients, and you double fold a little bit oblique. So if you start from the beginning with a little bit an asymmetrical neobladder, then you can double fold actually to make it a sphere again. So this is one side, and then we start closing as well the other side of the anterior wall. And then before closing completely, we have to bring in the neobladder catheter. And in the beginning, I was inserting the single J catheters through the anterior abdominal wall. And then since, I think already 3 or 4 years, I'm bringing them in together with the bladder catheter. So I'm using a 20 French bladder catheter, having the single J's fixed into the draining holes. And then it's very easy. In 1 minute, everything is inside. It's also inside the neobladder, so you don't risk to have a problem if you pull them out, that there would be a leak intra-abdominal. Pull them through the chimney and then do the anastomosis with the ureter. So here you see we have a nice Wallace plate. Everything is bleeding well, and you can do the classical anastomosis. So this is just the same as in Bricker diversion, but it is the mirrored position. And the chimney is at the left side and the Wallace plate is right. And for ileal conduit, it will just be the other way around. For this, I'm using, as Nick said, the Wallace plate is with PDS 50, and the anastomosis between the Wallace plate and the chimney is with Stratafix 40. Okay, and then we just finish off the anastomosis and do a leakage test. And then we're done. I always put in 120 cc. If you cannot put in 120 cc without any problem, then probably your neobladder is too small. All right. So I just, before closing and having some questions, maybe I want to share some complex and difficult situations, because this is always the difficult thing in neobladder, is to bring the bowel down. And actually there are 10 steps that you have to follow. And if you do, you will always be able to bring the bowel down. I have always been able, except for one time. So the first thing is, in male patients, try to preserve maximal urethral length. So this means go a little bit into the prostate and have an extra half centimeter or 1 centimeter. Reduce the Trendelenburg, of course, go to 10 degrees. And also, that was before we did not use the Dier seal, reduce the pneumoperitoneum, because the diaphragm is coming down and pushing the bowel down. So, but we are already on 8, so we stay on 8. If you're working with a robot between the legs, then the hips are classically a little bit overstretched during the ablative part, and then you have to flex the hips in order that the pelvic floor is coming closer to the camera. So bring the knees towards the head. Fourth thing is that you have to remove the sigmoid from the pelvis, as you have seen in the movie, and clip it with some fatty attachments to the peritoneum and the left fossa. Then bring down the good loop. Use barbed sutures to do the anastomosis, so you can gradually increase the tension. If necessary, you can apply perineal pressure. The assistant can do it. Certainly for the beginning of the first bites, this can help you to start up your anastomosis without tearing the urethra. If you see that it is not working, you can use small vessel loops around the small bowel. So you see this here, and the blue vessel loops make small mesenteric windows, bring in 2 vessel loops. One is held by the assistant and the other one by your fourth arm. Then the next step, if it is still not enough, it's early detubularization of the ileal loop. So this is also here in the right-hand figure. So you see there is still too much space, almost 10 centimeter between the bowel and the urethra, even if you use the vessel loops. And what you can do then is already open this whole 10 centimeter here, open at the antemesenterial border. And then you will have a flap, a tongue of tissue, and you can easily bridge many centimeters to bring it close to the urethra. At the beginning, then you have to close it, and you start again like a funnel, but this funnel will never kink because there is so much tension. I did this 4 times. The first time was after an ileocecal resection, so the bowel is hauled up proximally towards the diaphragm. And if you do this, well, then you have a nice anastomosis and the tension stays. So the patient, none of these patients needed to catheterize because of any risk of kinking. So it is not something that you have to worry about. And the last thing is opening the peritoneal covering of the mesentery. So make longitudinal incisions every centimeter, but be very, very careful doing this, because if you then tear the vessels, you lose the bowel. Last thing, so you see here, neobladder has been done, and now we have to do the anastomosis. You see the right ureter in its position, but the left ureter, well, is down there, a lot of traction. So no way that you're going to do a Wallace plate here. It is not working. So what do you have to do at that moment? You have to bring back the chimney to the right side and find the ureter at the level of the promontory, and then bring it back. So it is still crossing under the mesosigmoid, but it is not crossing anymore under the meso of the neobladder. So this happens if you have a short left ureter or a fatty patient, and then what you do is the left ureter is put halfway on the chimney, separate anastomosis, and the right ureter, you can put it at the end of the chimney. So that was the last thing that I wanted to share with you. And now I'm happy to receive any questions.
Thank you, Karel. Fantastic demonstration of neobladder. I particularly really liked the 10 points that you gave for one of the most vexing problems when you start off doing an intracorporeal neobladder, and that is the bladder doesn't reach. And all of us during the initial cases that we have done have faced this problem. And I think this 10-point cheat sheet is going to be a great help a lot of people starting off. I have a couple of questions for you and Nikhil as well, but I'm going to ask you first. One of the questions that has been asked by our panelist, Dr. Indranil Banerjee, and he says that any tips on doing intracorporeal neobladder after a salvage cystectomy? For that matter, should a neobladder or an intracorporeal neobladder be done at all when you're doing it after radiation therapy?
I have to say I have only a very small experience. I did 2 patients after radiation of the prostate. And actually I said to him, I don't know if I will be able, we will see. It depends. Some patients, they still have a nice anatomy. They do not have a very big scarring after radiotherapy, others do. And in 2 patients I was able, I saw during the dissection, was still nice. I even could do nerve sparing. And there I had a good outcome also regarding continence. But this is actually more rare than it is frequent. So most often irradiated patients, certainly not an orthotopic neobladder, maybe a heterotopic one, but an orthotopic is seldomly used. Do you agree?
Absolutely. I think, Nikhil, would you like to give your comments on this?
Thank you. You know, I'm obviously following on from Karel's comment. An important thing that we have seen now, is getting more and more salvage cases come through, because probably during the peak of the COVID pandemic, a lot of people had radiotherapy that they shouldn't have had. The 2 things which I have seen, and I've only done one this year, that was a salvage conduit, which I did because the patient did not want a neobladder, was that when I put the cystoscope in the clinic, he had multiple strictures. So I think, you know, post radiotherapy, if someone has developed multiple strictures, especially in prostate cancer radiotherapy in the UK and in Europe, a lot of people will have brachytherapy boosts, so they may get a stricture. And the second thing, which I was a little bit, and I did call Karel during this case, because, you know, I do call him a lot, actually. It was that there was a lot of bowel radiation change too, which I hadn't really noticed in the past, because a lot of the time we tend to see radiotherapy change post-prostate, but I think the field in the bladder is broader. And, you know, I had to make the conduit 35 centimeters from the IC junction because the terminal ileum was completely irradiated. So I think it is possible. It has been done successfully, but, you know, you don't want to do a neobladder and someone who's got multiple strictures. That's a no-no from the word go. And if you have a lot of radiation change to the gut, that might also swing your decision on the type of diversion you want to do. So those were the 2 points. Gagan, thanks.
Exactly.
Fantastic.
Thank you for this extra point, Nick.
Karel,
because indeed,
Karel, is it easy to catch a flight from Belgium to UK?
It was, but I took the train. I took the Eurostar train.
Right. Unfortunately, they don't have a train from Belgium to India yet, but one day we'll get there, I'm sure. The next question that I want to ask you is about, you mentioned in your presentation that you were able to send even these complex neobladders, you know, straight to the ward, and they don't need to go to the ICU at all. That's really interesting, because I think a lot of us actually send a lot of patients to ICUs, and only after 2-3 days they get shifted to the wards. What, you know, how do you manage these? In particular, how do you manage these patients in the post-op period? What tips of ERAS protocols would you like to give the audience which enables you to be able to have these patients out of the ICU on day 0?
So the most important, before we used air seal with low pressure and reduced Trendelenburg position, we were not able to do it. The anesthetists, they did not feel safe after a neobladder, and because this is a longer operation period, they did not feel safe to extubate immediately. So it began actually after we introduced this. And what we are doing now is that they are immediately extubated. The nasogastric tube goes out on the table before they awake, and then they can have small drinks at the first day, but not yet normal food. We try to mobilize them as fast as possible. And all the steps of the ERAS protocol that we are using before are and that are published is done here. So we use also metoclopramide intravenously, chewing gum, all these things that can help. All these small steps, altogether incremental changes will make it possible. But the thing that really skipped ICU was the low pressure and less Trendelenburg short operation time. That's the thing.
Fantastic. Karel, do you use albumopan in the post-op period? Do you have access to it?
No, we don't have access. If you can, certainly do it, because there is less ileus.
Gagan, can I join your question?
Sure. Please, sir, please.
Yeah, both these gentlemen, is a splendid presentation from the times when there used to be in 90s 10% elective ventilation for cystectomies. And I remember we would not get elective ventilator bed from what Karel and Nikhil has presented. My question is, are your ileus or bowel related complications are adjusted for the enhanced protocol or whatever protocols you're adjusting? Because why I'm asking is they become a routine, but the new observers or the participants of this webinar may not go into those fineries that those have become standard practice in your centers. Could you highlight that?
A couple of things, Dr. Bhandari. One is we have a very strict standardized protocol, which starts off right the way through, especially if patients are having neoadjuvant chemotherapy. We did notice a slight increased complication UTI rate in patients having neoadjuvant chemo. But coming to the preoperative bowel prep, so for conduit, it's just clear fluids. For a neobladder, obviously, they require bowel prep. A very important thing which I want to just mention is during COVID, we had no access to intensive care in my center. We had 48 ventilated people in my center at the peak of the COVID pandemic. And basically, my head of ITU said, if you want a bed, it's going to be a matter of luck. That's the situation. Whereas we do have access to a cancer postoperative ITU. And I think your anesthetist has a very important role to play too, to prevent ITU admissions. The reason why I say that is now, because you don't have to do an open incision, they don't really require a PCA or an epidural, which itself can exaggerate the need for a low blood pressure, hypertension, more monitoring with an arterial line. So all my robotic patients, and this is what I picked up from Karel too when he's come to our center very often, is they'll have a tap block, which will be local anesthetic Marcaine based. If they're very big patients, they may need a tap block the next day also. So, a regular PPI, a regular prokinetic, keeping them dry and not overfluid overloaded. Most of our patients on the ward, the length of stay for a conduit is 4 days, for a neobladder it's 7 days. So most people go home on day 4, day 5 after a conduit, which used to be 2 weeks when I was a trainee, in Newcastle. So lots of small steps have led to an improvement in the enhanced recovery protocol. Thank you.
Another question, Nikhil. I assume that semi-long-term and long-term for a conduit, HRQLL, quality of issues remain the same irrespective of the technique used, robotic or open?
Actually, Dr. Bhandari, we've just done a project on something called Iconic, which is a 20-center, multi-center collaboration. The robotic quality of life seems to be a little bit better. We don't know why. Probably the incisions are smaller. The wound-related issues are lower in the context of how they recover post-operatively. But the UTI complication tends to be similar. So I think longer data is required. But there may be a quality of life improvement now in the post-COVID situation because people are going home quicker. They have less pain. Their return to quality of life or return to normal life is quicker too. So, but obviously we're doing more work on the Iconic trial on this.
Thank you. Thank you. Back to you.
Karel, I'm going to be a devil's advocate here. All of us love intracorporeal diversions and it's a regular part of our practice. But you in the first few slides that you showed that the complication rates and especially the high grade complication rates have gone down after the implementation of the intracorporeal diversion program and the orthotopic neobladder that you do intracorporeally. How much of that is actually intracorporeal diversion and how much of that is actually your own increasing experience in the procedure and your team getting more used to it and your post-operative protocols being smoothened out and everybody, recovering fast because of that. So how much would you give credit to as far as the surgical approach is concerned, and how much otherwise?
It's a very good remark. And I have to say, this was my learning curve. So we had a standard open series, or where we did more than 500. And I compared the last 75 open with my first 75 robotics. So this was still with the learning curve included. And of course, if I would take now my last 75, maybe it's even better. But this was just an honest introduction. This is not randomized, of course. This is just changing from open to robotics. And that's what you can achieve if you do it with intracorporeal, in my opinion.
Right. So I think we are not going to let anybody else know that it's not intracorporeal. It's just experience. But yeah, I think it's been a fantastic session. Both Karel and Nikhil, they've really gone to the depths of the cystectomy and intracorporeal diversion techniques. I've learned something really, really new in a lot of aspects today. I really loved a couple of slides by both of you in trying to make this procedure simple. Before I actually wrap up and hand over to Dr. Bhandari, I'm just going to ask one question to both of you. And I would request both of you to answer it separately. For somebody who's just starting off in a robotic, somebody who's a trained urologist, they got a robot in their hospital, they've got a good bladder cancer practice. What few 2-3 tips that each of you would like to give to these surgeons who would like to have a robotic intracorporeal practice, how to go about it? Over to you, Karel, first.
Okay, well, first thing what I would say is have robotic experience in something else before you go to intracorporeal reconstruction. Start with prostates or something. Next thing is have a mentor, and also have a mentor training. So train first, train in a lab where you can make mistakes. Try it first there, then have a mentor that backups you. And last thing is that build a team. Build a good team with your anesthetist, with all the people around it. Show them the videos, that they know what you're going to do. Also the anesthetist, everybody has to know. Also for the ERAS protocols, everybody should be included. That's my advice.
Fantastic. Nikhil, your
thank you, Gagan. And just following on from Karel, I think case selection is important. Don't choose a BMI of 50 who has got T4 disease. You shouldn't really be doing robotically anyway, but someone who's got high volume tumor. And something which I picked up from Karel was when I went and did a dry lab with him in Strasbourg, was follow the principles that you would in open surgery. So achieve a negative margin, get at least 10 lymph nodes out, because bladder cancer is a non-forgiving tumor if surgery is not done properly. If you leave tumor behind, the patient will have cancer-specific mortality. And the third thing is collaborate, speak to others who are doing it, because whenever I go in Perceptor in the UK now, sadly, we can't travel abroad. I've just set up 2 centers in the UK this year. Within 3-4 minutes of seeing someone do some work on the console, you can pick up their experience. But I feel robotic cystectomy and robotic intracorporeal ileal conduit is certainly the peak of where you want to be. And whether we should do some more work on when we should start doing. So, if someone has done 4 prostates and they want to start doing a robotic intracorporeal ileal conduit, maybe that's not the right time. So insight, case selection, collaboration, and keeping all the principles intact is where I would put it, on top of Karel's points, of course. Thanks.
Fantastic points, both Karel and Nikhil. And from my side, I'd like to thank you for having spared your time and your experience in educating all of us. I'd like to thank the Vattikuti Foundation, Dr. Bhandari, Dave, Giovanna, for giving me the opportunity to moderate this session.
Congratulations, Karel, Nikhil, and Gautam.
Certainly, thank you very much for inviting me. Very happy to be here with Nick, my good friend, and it has been a very nice collaboration together that we will keep during our lifetime, I believe.
While I was thanking you for this wonderful webinar with so much latest about it. I can't withhold my comments for the participants because I have always believed that cystectomy and extrophy bladder, two procedures I know with my 5 decades of experience, are natural progression of your surgical skills and competence. They are iconic procedures, so I would refrain from getting excited listening to these experts who made things so simple with their illustrations and videos, and don't jump on your first cystectomy. It is a specialty within a specialty, and you'll have to really work as they have worked, shunning your egos, go to your worst enemy if he's the best surgeon, and learn this, because there are so many points these experts or we don't mention because they become a routine or standard of care in your center, but they do matter in long term. The point which I would like to say that always look at not these outliers who have really produced, like I've been listening to Peter Wicklund, I've been listening to seen Karel's work and all. They are progression, because when Peter Wicklund presented his first 20 cases at Henry Ford way back in 2006, the complication rate was high, and I was wondering why the hell he's doing this for that. And now you see how the things have changed. So still to remind you that the complication, minor and major complication rate after cystectomy are 20 to 40% in published literature. So don't ignore that part. And a word about Vattikuti Foundation. Vattikuti Foundation has one objective, which I have not changed. Mission is how do you improve patient outcomes? And we have taken 2 routes to that. One of them was technology. That technological interface improves surgeon cognition. And that's why we are sold to technology. Technology doesn't mean that it is Da Vinci. It was Da Vinci at that point in time, but we always would believe that technology would, leveraging technology would improve patient outcome. And second thing, what we have done is surgeon education. And that's what we have been talking. And these webinars are part of our mission to educate surgeons. And it's not that, excite them. Webinars would not make you a good cystectomy surgeon or a diversion surgeon, but it would excite you to go deeper into and pave your way to become excellent surgeons. Third thing, recently adding to this navigation plan of ultimately patient outcome is contributions from patient itself. And now we have moved over from our model of B2B, which is interaction with surgeons and hospital. Now we are preparing patients also to contribute their might, so that as a team, surgeon and patients, both stakeholders can hope for an exciting outcome. Thank you very much, gentlemen. This is not the last time I'm bothering you. Thank you, Nikhil, because I just pick up a phone and have a wave and I call him and it is done here. So continue doing good work and we will call upon you. And Vattikuti Foundation is really grateful for educating us and so many of us. And these recordings would be available to all of you. And thank you once again for sparing your Sunday for this activity. We appreciate it very much.